Hello and welcome to the Alabama Public Health Training Network.
Thank you for joining us today for our program, Building Excellence in Evaluation, Examples in Chronic Disease Prevention from Alabama. If you have questions about anything being discussed today, please call or email during our broadcast. The phone number and the email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to register for this program in order to access that material. I'm Dr. Jim McVeigh with Alabama Department of Public Health, Director of Bureau of Health Promotion and Chronic Disease, and I want to welcome you and our faculty present today. Nancy Wright, Director of Cancer Prevention and Control Division with the Alabama Department of Public Health. Julie Hare, Director of Public Information Unit of the Tobacco Prevention and Chronic Disease Branch of the Alabama Department of Public Health, and Dr. Ellen Jones, Executive Director at the Mississippi Public Health Institute. We will also have additional faculty members joining us by phone today. Dr. Deborah McCowan, Director of the Institute of Social Science Research at the University of Alabama. Dr. Jesse Saul, President and CEO at North American Research and Analysis, and Dr. Ross Brownson, Co-Director and Professor at Brown School at Washington University, St. Louis. Welcome everyone and thank you for joining us. Now we will begin our program with Dr. Bronson's presentation.
Thanks, Jim. I really appreciate being part of this webinar today. I want to give thanks to the people who have put this webinar together, who've provided a lot of the work in the background of the webinar. These are people both here in St. Louis, there with you in Alabama, and a few others from around the country. So we've got their names here, and I really appreciate their help. As Jim mentioned, I'll give you an introduction to evaluation and a call to action and set up the rest of the webinar today. In our training, we use what we call the evidence-based public health wheel, and you can see here it consists of a number of modules or components in the evidence-based decision-making process. It includes community assessment, quantifying the issue, writing a problem statement, searching the literature, prioritizing options, action planning, and then the focus for today on evaluation. An evaluation shows up here. When you evaluate a program or policy, you have choices about discontinuing it if it's not effective, disseminating it widely if it is effective, or often parts of it are effective and parts aren't, and you retool it and take it back in. And as we'll note in my introduction today, evaluation is fundamental. We also like to boil down the key characteristics of evidence-based public health or evidence-based decision-making. And here you see the 6 parts of it. I won't spend time going through each one, but the important thing is within the context of what makes a health department or public health practice evidence-based, conducting a sound evaluation, both quantitative and qualitative, is critical. You might ask why we evaluate, and this is something most of you already know. We're doing it for a variety of reasons. Are we meeting our objectives? Are we showing effectiveness? When we work in a governmental public health agency, there's this word called accountability that's very important. We're trying to share what we're learning with others. And maybe this last bullet, which is one we don't think about as often, is this idea of sustainability and whether through evaluation we can sustain our programs, build their effectiveness, and lead toward their long-term maintenance. And I listed here a tool that we've developed by a leader here at Washington University, Douglas Luke, the sustainability tool, which is a free online tool, and I encourage you to try that tool and use it. It's a very simple public health-oriented tool that will help you measure and contribute to your own program. This question, well, if I've got a program that's already been blessed as being evidence-based, why should I worry about evaluation? What if something's already been shown to be effective elsewhere? Why do I need to evaluate it here? And today, in my little introduction and in the case studies we'll illustrate coming in a few minutes, we'll show you why this is still an important component, even if what you're working on is already deemed as being evidence-based. With evaluation, we're trying to assess a number of different factors, and here's just some examples and a few more in the next slide They might be things like acceptance. Do they fit with the needs, the settings, the cultural beliefs of a population? How do our partnerships come into play? What if something's already been evidence-based? Type 3 evidence is what we call translational evidence or adaptation. So how do things need to be modified when they're being used in a new setting? And then reach. How do I make reach a priority? How do we address populations, maybe populations in Alabama with high health disparities who are not adequately being addressed in a public health setting? And other assessment-related concepts that relate to evaluation. Effectiveness, kind of the fundamental concept of evaluation. Are there other harms, potentially unintended consequences of an evaluation? Sometimes these are positive, sometimes these are negative harms. And then this concept of maintenance or sustainability I mentioned earlier. Are we looking at a long-term impact? Are these changes that maybe occurred in a short-term basis being achieved over a longer period of time? This is the basic definition of program evaluation. A few things I've underlined here in the definition. Doing this systematically and as objectively as possible, measuring effectiveness, and then measuring against your objective. So the stated achievements you're trying to reach, the objective, and how well your program or policy is meeting these. Often in evaluation, you hear this concept of triangulation. And this is often a method of quantitative methods and qualitative methods, or it can be using multiple evaluators to address the same issue. We'll hear some about this later when we talk about qualitative methods. And the sort of metaphor here you can think about is if you're looking into a room from the front window, you might see a couch and you might see a person lying on the couch. Maybe there's a ball lying behind the couch that you can't see from the front window. If you were looking in the back window of a house, you would see the ball, but you might not see the person. And so a triangulated evaluation helps you look at a problem or an issue or an achievement from multiple perspectives, kind of the same concept of looking at it through the front window or the back window. This question hopefully is rhetorical. When should we think about program evaluation? Well, of course, you should think about that from the beginning. Even though in our wheel it looked like it appeared at the end. And you can do retrospective evaluations, but they're never as effective as if you had thought about evaluation from the beginning. So that's really important as we build our programs. Most of you are writing grants to get your programs funded, and so when you write your grant is probably the first time when you think about evaluation of your program or policy, and that's appropriate. So what I want to do is briefly walk you through some of the wording we use and connect the concepts of evaluation from outcome, impact, formative, or process evaluation with concepts of program planning on the left-hand side of this diagram with your goals, objectives, and activities. And so I'm going to briefly walk you through each of these concepts on the right-hand side, outcome, impact, formative, and process evaluation. Formative evaluation can be thought of as a pre-evaluation. This is something that occurs very early in program planning. It's occurring before any program has actually been begun. It thinks about barriers to a program. It thinks about feasibility. It thinks about appropriateness of a program or policy to a certain target population. It occurs very early, almost as a pre-evaluation. In the next slide, we give a few examples of formative evaluation, attitudes among school officials, barriers. So let's say that you were designing in rural Alabama a healthy eating intervention for schools. Well, you might want to know what's been done before. You might want to know what the attitudes are from school officials or parents or the students themselves about some changes to the eating, the physical structures for eating or the policies, or maybe how snacks are brought in for various school events. And so all those sorts of issues would be formative evaluation issues. The next type of evaluation, I like to, so we're in baseball season and we're at the time of the year, the All-Star break for baseball, and I like to think of, among famous baseball movies, the movie Field of Dreams. And if you remember Field of Dreams, the movie with Kevin Costner, the famous quote is, "If you build it, you will come," or "If you build it, they will come." That's a good way to think about process evaluation. If you build a program, if you deliver a program, people come. They like the program. If they've come to the program once, do they come back a second time? Those are kind of the field of dream concepts of process evaluation. It doesn't tell you at the end of a program whether something achieved your objectives, but it tells you along the way what seems to be working. Are people satisfied with the program? Do they understand it? It's a direct extension of the idea of action planning, of how we're carrying out the activities in a program. And it can include both quantitative or qualitative data. But if it's quantitative data, it's very simple data. It might be simply the number of people who attended a program or the percentage of people who came back the second time were part of the program in the beginning. In the next slide, we show an example of process evaluation here. Let's say you're delivering an evidence-based program in diabetes, like diabetes self-management training, which is deemed an evidence-based program. For the recipients of that program, a process evaluation question might be, how satisfied are the participants in a diabetes self-management program with the program itself? And so that would be the example of a process evaluation. Another way to think of it in this cartoon, I like this cartoon, you think of the mad scientist over on the left-hand side and some miracle occurred over on the right-hand side. Process evaluation is trying to figure out in the middle what led toward that miracle or what led toward your program being successful or not being as successful as you would like, and you can think about that in a way as unraveling the black box. Then impact evaluation comes next. This is beginning to look at actual effectiveness measures, knowledge, attitudes, beliefs, behaviors. This is mainly quantitative data, and for most of your programs in public health, this is probably the most realistic endpoints. These are things that might occur 2 to 3 to 4 years out for a typical public health program. And so if you were working in tobacco control, an example might be number of cigarette packs sold in Alabama based on Department of Revenue data. So because cigarettes are taxed, you can get the number of packs sold fairly readily. Or you might use things like the behavioral risk factor surveillance system to look at the rate of smoking among men or women in Alabama or among African Americans or whites in Alabama or among lower SES or higher socioeconomic status individuals in Alabama. So a variety of ways you can measure impact evaluation based on data that already is being collected there in Alabama. And the last type of evaluation is longest-term outcome evaluation. This begins to look at things like changes in morbidity or mortality. So this might use cancer registry data or data from birth certificates around the rate of cardiovascular mortality or the rate of diabetes mortality. Outcome evaluation is always quantitative. It's often what we use in our long-term strategic plans that look at a window out 5, 10, even 20 years sometimes. And we can think of examples, what areas of Alabama have highest rates of heart disease mortality? Or what are the trends in heart disease mortality over time in Alabama or in another state? Those would be examples of outcome evaluation. Paradox with outcome evaluation, it's often some of the easiest data to get, but it also is some of the longest term data. So for a program to really show impacts on outcome evaluation in our areas of chronic disease prevention, as we're talking about today, you might be talking about a window of 5, 10, even 20 years out. So quite long term, but still important when you're thinking about a comprehensive evaluation approach. So let me summarize a few of the key points and why we're here today to talk about some of these case examples. We need to develop good frameworks for evaluation. You'll be hearing about some more on that topic in just a minute. We need to share lessons. What are lessons we learned in one program or content area that could be applied to another area in public health practice? We tend to get kind of siloed in public health, and so we want to be able to think across program areas. And then our last presenter today, Ellen Jones, will talk about qualitative approaches and how qualitative approaches are really critical for informing evaluation. We have a number of evaluation resources available to you, and these will be talked about again later in the webinar. We have the CDC work on program evaluation. We have the community toolbox coming out of the University of Kansas. We have the Cypher Net Search resource. And then finally, we have some nice resources from the University of North Carolina. And we have our own evidence-based public health modules that are available that will describe some evaluation approaches as well. And so I'll conclude there, and I will hand back the webinar now to Jim to keep us moving along to our next presenter. Thanks very much.
Ross, I wanted to personally thank you for volunteering to work with us over the last year and a half. It's really important for us to improve our ability to evaluate our programs, because in these critical times in public health and the rapidly changing environment we're in, it becomes even more important not for us just to do good things because they're good, but to prove that they're cost effective. And so we have to look at everything that we're doing, and the fact that I wanted us to get as many people to benefit from the training that you're working with us on, the fact that we have over 200 people in the state of Alabama that have registered to be a part of this program today, the fact that we have over 32 other states with representatives of over an additional 200, so we have over 400 people that have registered for this program. That shows the need for us to have a better understanding of how to improve the evaluation we have going on. And I do think it's very important for us to look at concrete examples of evaluation. And Nancy Wright, the Director of the Cancer Prevention and Control Division with the Alabama Department of Public Health, will be talking about the WISEWOMAN program. Nancy, take it away.
I appreciate it, Dr. McVeigh. I'm here today to share with you our experience with quantitative evaluation with the Alabama WISEWOMAN program. The Alabama WISEWOMAN program was designed to reduce cardiovascular risk factors among women that participate in our breast and cervical cancer program. It's a screening program that's provided statewide by the state. And for those women that come in, we want to be able to offer, in addition to cancer screening, help with those risk factors. We do that by screening for additional risk factors, by providing risk reduction counseling based on what those risk factors are for that patient, and by providing healthy behavior support in the form of health coaching by a social worker or an evidence-based lifestyle program. The risk factors that we focus on for this program are smoking, weight, high blood pressure, high cholesterol, and diabetes. I want to begin an overview of the evaluation with where we are now, and that's the results that we have now based on 2 specific evaluations. These are physician notes regarding 2 WISEWOMAN patients within the clinics. WISEWOMAN recheck showed a 10-year risk reduction in the cardiovascular risk factors from 5 to 3. The weight was stable. They were eating less fat and fried foods. Cholesterol, specifically LDL, was down in their specific measurements, and blood pressure on recheck is there, which showed controlled hypertension. Another result that we were able to document from the physician notes was that a patient lost 29 pounds since joining the WISEWOMAN program. And this was their second visit. So as of the second follow-up visit, they had lost 35 pounds since joining the program. And the blood pressure on this date was showing controlled hypertension. Now that's a lot of quantitative data, but with that data we're able to see whether or not we're moving in the right direction when it comes to our big outcome, which is, are we reducing the cardiovascular risk factors? So how did we get there? How did we collect data so that we could show results like that? And then what can we attribute to the results that we're seeing? Those are the 2 big questions that we were designing when we began the program and we started our evaluation. Do our objectives match what we're trying to accomplish with the CDC funding? What results specifically do we want here in Alabama? What questions do we need to ask to get the results that we want? Does the data that we collect really answer the questions that we want to answer? Further, how do we collect that data? And then when we do collect that data, again, does it really represent the question that we have? And do we need to collect that data? Is it something that we can actually use? In the end, the question that we kept asking ourselves when we were designing the framework of our evaluation was, what is Alabama's story? what is it that we want to be able to show that we've accomplished with this program. And when we got lost down the millions of rabbit trails that you will tend to go down when you're constructing an evaluation framework, that was always the question we came back to. What is our story that we want to share? And in our particular instance, we were looking at, does a social worker effectively reduce cardiovascular risk? Does providing health coaching in this environment, when you're aware of your risk factors, help to reduce that factor by changing your behavior? There were several tools that we utilized, several activities that we went through. We went along this journey of developing an evaluation framework. And these will all be very familiar with you, I'm sure. We did have the logic model, which kind of is an outline of, if we do this, will it lead to what outcome we desire. We also had a flow chart, and this was an invaluable tool because our program was based a lot on how patients flow through the clinic. So it was, what will we do, how will we do it, how will the patient get there? And then with that flow chart, we could make sure we were collecting data at every single step. A work plan, SMART objectives. CDC also had their own requirements, as this was part of their funding, and data collection was, of course, a very big part of their program. And then also, we put a very strong quality improvement focus into our framework, and this is something I'll touch on a little bit later. So utilizing all of those tools, we were able to determine what questions we wanted to ask so that we could tell our story. We made sure all those questions were on actually paper tools, and the main tool was a one-page, two-sided document. The first side was what we call the patient assessment intake form. Basically, it was an opportunity for the patient to document what their behaviors were, what their nutrition intake was, what their exercise activity levels were, and also knowledge of their health status. Did they have blood pressure? Did they have diabetes? And then we also had the clinical side, which was the office visit form. What were the lab results? What were the results of that risk reduction counseling? Were the patients ready to change? Did you set goals? And then we had a second separate data collection form that the social worker actually completed, called the social work contact form. This form collected what was happening in that social worker environment. Were they goal setting? If so, what were the goals they were setting? Were there referrals into the community? Was there assistance with medication adherence? Those type of variables. I want to touch one more time on the quality improvement frame. Often when you approach, or when we approached the clinics, when you use the term evaluation, this program is, evaluation is a strong component. We'll be here often. They think that we'll be maybe collecting data, and then at the end we'll come back with a big report that says you succeeded or you didn't. They're used to more of the outcome-based. We were very careful from the beginning to involve the clinics and let them know, yes, the goal is to reduce cardiovascular risk factors, but in the meantime, we have to know, are we headed in the right direction? Are we, is what we're doing and beginning actually working? Because if it's not, we want to be able to adjust it at the end and improve it. So we began with an advisory council that actually had the staff from each of the clinics that we were working for or with on that advisory council. So they assisted us in looking at our first set of data. We looked at the first 6 months of when we were providing this patient care through these two clinics, and we showed the data to the clinics, and they helped us interpret what does it mean that only 30% of patients only got 2 health coaching sessions. What happened between those 2 sessions? The number of women enrolled is this number. Is it higher or lower than we expected? Are we reaching the people that we want to reach? Those are the type of things that we did together when we were looking at that data. We did find several opportunities to improve, and then we came back for a second round for another 6 months of data, and those improvements that we had talked about were reflected in that data, so we knew we were kind of moving in the right direction, and then of course we found more opportunities for improvement. After looking at those 2 sets of data, we can honestly say we believe what we're doing is working. We're already seeing decreases in weight. We're already seeing decreases in blood pressure. Patients are really responding to the support groups. Patients are also having better controlled hypertension. Patients are getting off of medication that's not necessarily needed because their health is improving with their diet and exercise. Often the ones that are benefiting the most are the ones that are involved in the support groups. So we are able to use a lot of this information to then target, well, then we need to get more people in these support groups, if the support groups is the key to what's working. We also realized there were several opportunities to improve, and the next couple of slides are just examples of some of the areas that we looked at to improve. We needed to increase the number of women that were going through. We needed to look at the cost, of course. We needed to look at additional blood pressure data rather than just what we were collecting at support groups and on the baseline form or the data form. So we wanted to look with the clinic, within the clinic's EHR. So if the patients came back again, what did that blood pressure look like? We needed to define better what health coaching was. Often health coaching was happening and the social worker wasn't even really counting that as a health coaching session. We needed to focus more on hypertensive women. We wanted to increase patients returning for health coaching. We also had to improve the data form so we could better capture some of the medication adherence activities that were happening with the social workers. Again, this is just an example, a very brief one, I know, of how Alabama approached starting an evaluation plan, the tools that we were using, and the ability to frame it more as a quality improvement effort so that evaluation doesn't look as threatening and everyone involved is more participatory in improving it so that we can, at the end, document what contributed to these changes and are these the changes that we were looking for. Our experience was positive so far. It's been a group effort with the clinics. It's been continuous. It's definitely not been a one-time event. It's what we make it. We meet regularly and we ask hard questions and we keep coming back to what is the story that we want to tell, not just what's required or what's the outcome, but what do we really want to find out so that we can share with others so that we can have a significant impact on women across the nation, not just women here in Alabama. I believe the quality improvement approach works, and I really believe you have to know your story and own your story. Figure out really what it is you want to accomplish, and then follow that. You're in a framework of a CDC grant, at least in this situation, so there are core variables that are required to be collected and that will ultimately come in an outcome evaluation, and we'll see hopefully changes in risk factors and incidence and mortality. But in the meantime, you really have to get a handle on what it is that we're doing that's making that difference. Here's our WISEWOMAN team. Rhonda Holland is a social worker, and she's a program manager. Ann Dageston and Kamari Sitala were the data managers for the program. Kamari is here today if there's further questions about the ins and outs of evaluation data. Kitty Norris is our clinical manager. We did have an evaluation consultant, Allison Litton, and then I direct the cancer division. I believe now it's Julie Hare's turn to talk about tobacco.
While Julie's getting ready, I'd like to go ahead. It's really rewarding for me to see how public health is changing, and the fact that 24 years ago, our new state health officer at the time, Dr. Don Williamson, asked me, Jim, if you could have one program, what would it be that we need to do in public health? And I said, we're not doing anything to address cancer. And since that time, we've had an outstanding breast and cervical cancer program that has taken off and saved so many lives. And now that cancer program is branching out to those women that were being screened for breast and cervical cancer. Now they're being addressed in other potential chronic disease conditions and risk factors. And it's really rewarding to see how public health is evolving, and it will continue to evolve. So it's all the more important that we evaluate. We used to have the luxury of doing good because it was good. We now have to prove that we're cost effective. Everything goes back to the bottom line. And is this saving money as well as saving lives? And this is an example of the type of evaluation that we have to put forth to others. And another example that we have, Julie Hare, our Director of Public Information Unit with the Tobacco Prevention and Control Program with the Alabama Department of Public Health, will be discussing the quit line in our evaluation. Julie.
Thank you, Dr. McVeigh. So let me tell you a little bit about how we wrote our evaluation plan. Let me give you a little bit of background first. Let's go ahead. There we go. CDC awarded a grant to the Tobacco Prevention and Control Program to ensure quitline capacity. It was actually the PPHF 2014 Tobacco Use Prevention Public Health Approaches for Ensuring Quitline Capacity Grant. It is for the period of August the 1st, 2014 through the end of July 2015. It's a one-year grant, renewable annually every year through 2018, excuse me, it's a four-year grant. The grant required the development and implementation of a comprehensive evaluation plan. So the grant started August the 1st. We came up with an initial evaluation plan that was supposed to be submitted with the FOA. A full evaluation plan was supposed to be submitted 6 months later with the progress report. But the first one that we submitted, we worked around for a while, and we submitted expanded versions of this to a group at CDC and the Quitline Work Group for their feedback. They gave us some feedback on it and said, hey, you need to expand the program description, you need to add some evaluation questions, and you need a logic model. So it wasn't long after we got that feedback that we learned that CDC was going to extend the deadline to April the 29th of 2015. So that gave us a little bit more time to work on it. And at the same time we were working on this, we also learned that we had to submit our annual progress report in April as well. So there were all kinds of things going on at the same time. Welcome to public health. The first lesson that we learned, and I'm sure that most of you know this, is that evaluators with content knowledge are a plus. It is just absolutely crucial that your evaluators know about your program and have some experience. Our evaluators, Dr. Deborah McCallum, who's with the University of Alabama, the Institute for Social Science Research. Sarah Dunlap is also with the University of Alabama. And Dr. Jesse Saul with the North American Research and Analysis Incorporated were our evaluators in helping us write this program, this evaluation plan. They're both on the phone today with us. If you have some questions at the end of this part of the program, they will be more than happy to answer them. As I mentioned, it is important that your evaluators have some experience and knowledge of your content. Dr. McCallum has worked on our program with several CDC projects. For example, she helped us write the state plan. She's done our core grant evaluation, adult tobacco survey, and has written several return on investment documents for us. So she and Mrs. Dunlap completed the initial drafts of the evaluation plan and logic model, laying a solid foundation to expand from as requested by CDC. Some of you may be familiar with Dr. Jessie Saul. She was previously the research manager with the North American Quitline Consortium. She brought a wealth of knowledge regarding quitlines to the table. So she worked from the foundation developed by Dr. McCallum and Ms. Dunlap, and she was able to expand our evaluation questions. So the combined knowledge of these evaluators really contributed to making the process a little bit easier. Also, kudos to our evaluators for speaking English. I think sometimes evaluation has its own language, and there's some of us who speak it better than others. So both groups were able to communicate their thoughts with us, and we were able to understand and appreciate writing this evaluation plan together. Which leads me to the next lesson, communication. Early and often. You can never communicate enough, as we found out. We already felt like we were a step ahead because of the knowledge base that our teams possessed, but everybody interprets things differently. Everybody sees things differently, so if you can come together and have your discussions and some communication before you get a whole lot further into the program, it's just going to be to your advantage. For example, we all got together to make our final edits together instead of individually. When we had our draft plan for evaluation, we actually put ourselves into a room and got Dr. McCallum and her team on a conference call. We walked through every single line on the evaluation plan. We just put it up on a big screen in the conference room, and we went through line by line and made sure that we were all on the same page with the things that we were talking about in our plan. I think we ended up at least staying in there for about 4 hours straight, but it got us through the process, and we were all on the same page when we finished. This way, it actually saved us time by putting it, by being together in that one room for those many hours, because this way you didn't have to keep going back and forth to everybody to, through email or phone calls to see what was going on. So lesson 3. Know your data sources. What do you need versus what do you have? When we talked with Dr. Saul to expand our evaluation questions, she asked lots and lots of questions, wanted lots and lots of details about the program. We talked about our protocols, our services available, the frequency of reporting. So with that information and with her knowledge of quit lines, she was able to give us a very comprehensive list of potential evaluation questions. Our job was then to go through all those questions one by one and determine if it was something that measured something that we were interested in and if we already had data available from our quitline vendor. This took a little bit longer than we thought it would because at the time we had just changed vendors, so we weren't quite as familiar with what data sources and reports our new vendor had. For the most part, we had all the data available that we needed, but we had to have some further discussions about the evaluation questions if there was no data available. So some of the questions that we asked ourselves were, what steps would need to be taken to create the data source? What would the cost be to create the data source? What will we do differently as a result of gaining this information? In other words, did we have the capacity to change the program as a result of the findings? So going through this process forced us to prioritize our evaluation questions and actually helped us communicate better with our new vendor on what our data needs are. Developing a plan takes longer than you think. This was a lot of us. This was our first experience in developing a full evaluation plan, and it took a lot of time. There were a lot of players at the table, a lot of moving parts. I think when we completed writing the plan, we looked back over and figured out that probably we spent about 200 woman hours working on this final draft of the plan. And so let me just go over this one more time. This is a recap of the activities involved in the development of our evaluation plan. We reviewed and edited multiple drafts of the narrative and evaluation questions. We got feedback from work group members and the CDC and then incorporated it into the plan. We created a logic model that included outcomes that were important to us here at ADPH, but also included the outcomes required by the grant. We had multiple conference calls and emails with evaluators answering questions about the quitline program, so evaluation questions could be expanded. We had multiple correspondence with our quitline vendor regarding availability of data points that were not included in standard reports. And we prioritized and reframed evaluation questions based on our data available and our capacity to change the program activities as a result of the findings. And the last thing I want to leave with you is that you are never really done with an evaluation. You may think that you've written it, but it is now living, moving, breathing, and you've got to keep up with it, and you've got to keep changing it and adapting it to your program. We felt like we came up with a good plan. We were able to submit it on time to CDC. We are waiting on their additional feedback. But it doesn't mean that it's finished. We keep working with our vendor to capture and disseminate the data needed to answer the evaluation questions. We also are in constant communication with Dr. McCallum and her team at the University of Alabama to make sure that she's got everything that she needs to implement the plan and analyze the results. We also work with other areas of the tobacco program, such as our communications plan and our disparities program, because we want to be aware of the type and timing of any efforts that in which we are promoting the quit line. That way we can look at the quit line data to measure the impact of these efforts. We also know that our evaluation plan could change over time as our program changes. Like every other state agency, we are looking at potential budget cuts, and we know this could impact our quit line services, which would then change our evaluation focus. So in the end, the evaluation plan will be used to measure outcomes and impact of quit line activities. It was a lot of work. It was a lot of communication, but in the end, it's going to make our program stronger, and it's going to keep us on the right track to evaluating our program and providing quality services. So here's some contact information. If you have any questions or you want to email or call later, that will be fine too. Just let us know.
Julie, we really appreciate that presentation, and it shows with our limited funding, limited resources, we have to be very effective and make sure we all believe we're going down the right path, but we need to be able to prove to others that we aren't going that right path, and do we need to modify. And I appreciate all the time and effort that you put in with others to come with a good evaluation plan. I realize it takes a really good woman or 4 men to come up with a good plan, so thank you for your work. And with that, I'm very pleased to have Dr. Ellen Jones with us, the Executive Director of the Mississippi Public Health Institute, and talk about benefits and uses of evaluation.
Thank you, Jim. And I'm especially glad to hear folks talking about evaluation plans. Ross, our first speaker today, often says that public health practitioners deserve to get somewhere by design, not just by hard work. So I'm glad to see that folks are implementing evaluation plans. It's really important. I want to talk to you today a little bit about the benefits and uses of qualitative evaluation, because in public health we've done a really good job with quantitative evaluation, and we're just starting to use qualitative evaluation. So why do we use qualitative evaluation? Well, first, let me tell you that when I teach students at the University of Mississippi Medical Center, I tell them to remember that quantitative tells the what, and qualitative tells the why and how. So quantitative usually involves numbers and rates and measures, and qualitative involves understanding the why and how of different health issues. So we do qualitative evaluation for 3 different reasons. We want to assess, we want to listen, and we want to learn. So what is it that we want to assess? Well, we want to figure out what are the attitudes, the preferences, the perceptions, the background, the history of the people that we're serving. What do they think about this issue? What's likely to motivate them? And it also lets us do things like get in touch with some of the unheard voices, perhaps some of the people that aren't in our BRFSS interviews, to get stakeholder buy-in. We do this kind of qualitative work with policymakers often. We do it with school boards, with local city councils, boards of aldermen. So to get stakeholder buy-in on the front end, to understand what motivates them and what interests them. Because being right isn't the same thing as being effective. So while we have really good public health data, we need to understand what motivates local policymakers and decision makers. And also to figure out what are the assets and needs in the communities that we're serving. We learned early on in Mississippi, for example, that folks thought the community colleges were an asset. Well, that was something we hadn't really considered in our public health programs, but we use it very extensively today. And so what does this picture of the 2 dogs mean? Well, this is a story that I use to remind myself why qualitative information is so important. We were doing a physical activity and healthy eating program in a small, rural, low-income community in Mississippi, in fact, in the Mississippi Delta. And the participants were primarily women. We met at the fire department because it was the place in town that had the biggest meeting room, so we met at a table in the back of the fire department. And after we'd been up for several weeks and we had goals and objectives and we seemed to be working towards achieving those objectives, they said to me, "Ellen, we've quit taking physical activity." And I said, "What do you mean you've quit taking physical activity?" And they said, "Well, there are a lot of loose dogs in the neighborhood, and so we can't walk anymore. There were too many loose dogs." And that wasn't something that I had considered back at the central office, that being safe on your walks was something that we needed to think about. Would I have known that had I stayed in the central office and written up their plan? No. So you have to go out and talk to folks and find out what it is that are facilitators and barriers to the kinds of things we're working on. Another thing that qualitative evaluation helps us do is be better listeners. We get lots of guidance from very good agencies like NIH and HRSA and CDC and some other groups like Robert Wood Johnson and the Kellogg Foundation. But really we have to take that information and go out into our communities and listen for gut reactions. Listen to the why and the how. Listen for some unanticipated results and learn some strategies to reduce the underserved. This picture is men in the Mississippi Delta that are actually working in a hoop garden, and I've got it here to remind me that when we first went and talked about gardens in the Mississippi Delta, gut reactions, one was that real men don't garden. And so we started a campaign that real men do garden, and these guys and some others were gracious enough to pose for some pictures with us. But another gut reaction was from an older group in the Delta, probably over 50, that to them gardening harkened back to days of poverty, and that people who gardened were people who didn't have money to go get groceries. And so they didn't want to start a garden because then it brought back images of folks who did not have money for groceries. And so there are a lot of things that you have to go and listen to find out what some of the barriers are, not just count the numbers of people who do or don't have certain risk factors. It also helps us learn some unanticipated results. You might find things that happen that are good or bad as a result of your intervention that you would not know if you don't go out and listen to folks. And to learn some other strategies to reach the underserved. I've mentioned community colleges, faith-based communities in Mississippi are another. We've learned that radio is very important in the Delta. So to go out and listen and learn some strategies that you might not have used otherwise. These are a lot of the qualitative measures that we use. I'm guessing you're familiar with some of them. One that most people are familiar with is number 2, which is focus group interviews. And that's where we have usually 10 to 15 individuals in a room, and we have a moderator's guide and ask a set of questions that spark discussion around certain issues. But there are also individual interviews, and we use those especially with folks that might not participate in focus group interviews, perhaps policymakers or individuals who are very busy. We also do document records and reviews. We've done this with, for example, first-year medical students and second-year medical students and third-year medical students as they're going through their program. They keep a journal, and we do a lot of record review about patient interaction. We also do case reviews, and I bet a lot of you have done case reviews with community health workers where you're looking into an individual case and charting it from start to finish. We do a lot with observation because going out and observing can teach us a whole lot that we never got in the textbooks or that we never got in our quantitative surveys. So we do a lot of observations. And then photo voice or photos or other digital means are when we let folks in the community go out and take pictures or document what a certain thing might mean to them. For example, if we asked high school students to take pictures of places that they get exercise or places that they're physically active, it'll give us a pretty good picture of what's going on in that community. And then lastly, we use GIS or spatial mapping where we can overlay different things like poverty levels, community parks, and transportation. I want to tell you a little bit of an example about observations. In Mississippi, we recognized that the WIC program was having significant drop-off of mothers after the babies turned 1 year, and we can't figure out why that's going on. So we did some focus group with WIC participants. We did 12 focus groups. We also did 10 observation studies with 2 observers at each. And it's given us some rich information about the program that we wouldn't otherwise know. So we have a guide that we developed with the WIC program director and with the field staff, and the 2 observers have gone out to 10 different WIC sites and followed clients through the WIC program. We have 2 observers, in part back to Ross's comment about triangulation, because 2 heads are better than 1, and one might see things that another one misses. We've also got this observation form that follows the WIC protocol, but also listens to how the patient or client is treated, some of the discussions that happen, some of the health education that's given, and gives us a richer understanding of what's going on. And we're also trying to understand and replicate what's successful. So when we did the focus groups, we did, I think, 7 focus groups in highly successful areas, 7 that had a high drop-off rate, and 3 that had a very low drop-off rate, so we could learn from the ones that are high-performing. So I would encourage you, when you do any kind of qualitative data, you want to look not just at the areas that you're having difficulties, but look at the areas that are succeeding, so that you can find some themes and some success stories that you can replicate elsewhere. Another example is we did focus groups of policy leaders in Mississippi, and what we were trying to find out is, do local policymakers support policies at the local level, things like complete streets, clean indoor air laws, funding local parks, those kinds of things. And so it's important when you're working with policymakers to use skilled facilitators. Policymakers have a lot of worries that maybe perhaps your regular folks don't have when you're doing focus groups. So you want to have 2 note takers in every room. Sometimes it's very difficult to tape record policymakers. We found that they don't like to be tape recorded, so we have 2 note takers in the room. Make sure that folks understand that it's anonymous and confidential, and have your consent forms well written. Explain to them the uses of the data and how this kind of data can help decision makers and policy makers better meet the needs of their constituents. And then when you go in, make sure you have a level playing field, so that the newest alderman in the room has the same voice as someone who may be a 2-term mayor. And then you always want to report your results back to the group and help them understand the action step. What is it that they can do to make progress in improving healthy communities? So some benefits of using qualitative methods in these examples. Well, through the WIC observations, we were able to do things like figure out how much fidelity the staff had to the WIC protocol. Where were they going off the reservation, and where were they really following the protocol? To assess the client interactions and reactions, we learned a lot of things about customer satisfaction, client interactions, how much downtime there was in a visit that really didn't make the best use of the patient's time, and to identify ways to improve the program that we'd have never learned in a survey. So benefits, additional benefits with the policy leader focus groups, we found that one person's ideas generated more ideas. The policymakers seemed to play off each other's ideas and kind of want to outdo each other, which for us was a really good thing, because they were talking about community health improvements, and now they had said it in a public setting. It helped us have a good gauge of political will around certain issues. For example, in Mississippi, there was very little political will around sugar-sweetened beverage. There was more political will about walking trails and bike trails. Note reactions to ideas. You want to figure out where's the right time to intervene, and where are you going to have some political will to move forward. And we got a lot more information than we could have otherwise. Yes, we can track their voting records, and we can count the numbers of ordinances that we have, but by talking to folks, you really get a much better idea of where you might have a chance to implement policies and programs. So in conclusion, it's my opinion that data tell us what is, and people tell us what will be. And I've put up a postcard from Mississippi that shows that the state bird of Mississippi is the mosquito. And I wanted to do that because early in the days of West Nile, we were doing a very good job of surveillance. We were tracking West Nile, and we could do a good job tracking the health outcomes in cases, but we didn't have any idea why residents in Mississippi were not using insecticides and following some of the public health precautions that we had recommended. And so we did 12 focus groups across the state. One of the things that we heard was that people were confusing DEET, which is the active ingredient in bug spray, with DDT, which was an agricultural pesticide that was banned in the United States in 1972. And it was banned because folks were afraid that it caused cancer and that it had environmental effects. So there was a lot of fear that we were actually putting DDT in bug spray. And actually, DEET is a completely different chemical substance. It's safe. It's even been approved by the American Academy of Pediatrics for use with children. And so we had a lot of work to do education about the difference between DDT and DEET. But otherwise, we would just have known how many cases of West Nile we had and how many people were telling us they weren't using any kind of insecticide or taking precautions. And so I would say that a combination of both quantitative and qualitative data gives us the best possible case to go out and implement policies and programs and to measure their effectiveness. So some resources for qualitative evaluation. There's a CDC framework for program evaluation that I bet a lot of folks are familiar with. There's a section on qualitative evaluation in there. Also, the Community Toolbox from Kansas. And UNC has some program evaluation resources at their evaluation center. And then the online EBPH models that have been mentioned before, and all of those will be available at the Alabama Department of Public Health. Authors to look for, this Corbin and Strauss book is probably always about 3 feet away from me. I rely on it a lot. And it's very helpful if you're looking at hints for qualitative assessments, observations, focus groups, anything that you might be doing. I hope that these resources will help you. Be happy to answer questions if folks have some, and I would encourage you to just think about qualitative evaluation when you're doing your evaluation plans. And now I'll turn it back to Jim.
Ellen, thank you so much. It's real important that we continue to improve our abilities, that we are always looking to try to make public health better. And what we were doing with this particular program, and start off with Ross going over the evidence-based public health and a framework of how we can look at public health, and for us to improve our evaluation capacities, and then looking at the very real examples of the WISEWOMAN program and the successes that we've already seen there. And then we showed the example of our quit line and how we are trying to evaluate so that we can improve that. We also wanted to hear from Mississippi and all the things that Ellen is involved in for examples of how we can improve our evaluation and improve our program so that we're more effective. All of us want to be more effective. We want to do what's best. And how can we show others that we are being effective as we believe we are? The resources that have been put up here, if you have registered for this program, you will have access to this by going to our website. And if we have any questions, we'll be more than glad to take them at this time. But we wanted to give everyone on this that's watching this program the advantage of what we have had from working with Washington University and trying to show that with a little bit of a additional effort, we can even do a better job of what we're doing and be able to show other people what an outstanding job we're doing. I was a real proponent of being able not only to offer to a few select people on our staff with the health department, but also to make it available and so that other people will be able to follow up and contact some of our speakers and improve what they are doing. It's so important that we continue to try to improve. And if we have no questions or any other further comments from our panelists, I want to thank you for taking your time of being part of this program, and we'll look forward to working with some of you in the future.
Thank you.
I have one comment.
All right, Nancy.
It's more of a story, actually. When we first submitted our evaluation plan to CDC just to get some feedback from our project officers, it shocked me that one of the initial things they said was, well, it looks good, but, you know, we also want qualitative data. And I have never heard CDC really be interested in qualitative data before. And I thought, well, okay. I was expecting kudos for it being so strong in the quantitative section, and you know, now we're being challenged to add qualitative. So of course we did. We had some patient surveys and that sort of thing. You know, evaluation as a whole is somewhat intimidating, which is why we had a consultant to make sure we were on the right track. And then when you throw qualitative in there, it gets a little bit more intimidating because it's a field that I know about, but am less sure because it seems less concrete. But following that call, I was able to see your presentation, and it just kind of hit me, and it should have earlier, but it didn't, that we had already been doing qualitative data and didn't even recognize it. And what we weren't doing was documenting it or framing it in a way that it could be consistent across clinics. You know, we had gone to some support groups, and we had watched the dynamics between those women. We'd see them pass cards around when a loved one died. We'd see them crochet little crosses that passed around. We heard them share their success stories with each other. It never occurred to me really to document it. It just made me feel like we were doing the right thing. But after your presentation, I thought, well, that's observation. You know, we absolutely need to make sure we're documenting those things. And that, coupled with CDC saying, where's the qualitative, just helped put it all together for me. So we're beginning now to do more than a patient survey, and and do more individual interviews and more observation, and capture that subjective data that, as you so eloquently showed, really gives you what the story is inside all the data that you have surrounding it. So, I've already benefited from your presentation and hope to continue to learn from you. One of the questions I had about observation is, when we were watching the support groups, we didn't really announce ourselves. We were just observing. And now we'll start documenting. And you had mentioned that you had a WIC protocol, and they observed the WIC protocol. Well, we've got our flow chart, which is how the patient goes through. So it strikes me that we could observe the patient flow and use that qualitative information. But is there a question of, is it okay to not announce yourself, Or is it something where you really need to engage the patient in the beginning? I'm going to be following you and watching everything you do. So, please don't, think twice about it. But at the same time, if you do that, then everybody's going to start acting better, possibly, than they normally would. So is it okay to just kind of observe out of sight?
Yeah, that's a really good question, and ethical issues come up in qualitative data more frequently probably than quantitative data, because the researcher is involved in the collection of qualitative data all the time. And so in the WIC instance, we did announce ourselves. We asked patients if it was okay. We did that with the person who was from the Public Health Institute making that explanation rather than the person who was from the health department, so that they could say, we're here as a third party, and we're here because we understand that a lot of people are dropping out, and we're trying to help the health department figure out how to do better here. And so some of it is in the presentation of how you're doing and why and how the data will be used. Do they change their behavior, and do the practitioners change their behavior? Perhaps, and I think when you write it up you should recognize that. But having said that, I think when you see some of the shortcomings that happen even with an observer in the room, you can imagine what might be different without an observer in the room. And so if it's a one-on-one and we're following an individual client or resident of the community, we probably announce ourselves. If we do things, and we have a consent form as well, and if we do things where we're observing perhaps elementary school PE in a large group, we might be working just with the school and not with individual teachers or individual students, so a little different scenario. But I think it depends on the case, but you always want to make sure that, just like with human subjects and any other kind of evaluation, that you're thinking of those things on the front end and doing your best to make sure that you're ethically responsible.
Thank you, Ellen. And Nancy, thank you for bringing in this real-world perspective and how we can use what is, in theory, a good idea and then bring it to a very practical use. And that was where I see the real value of this, and why I was so interested in us wanting to discuss this further. So thank everyone for their time, and if we have no other questions, we'll just thank everyone viewing for their time also. Have a pleasant